Okay, good evening, ladies and gentlemen. I would like to welcome all of you to the webinar conducted by the Faculty of Critical Care Medicine, College of Anesthesiologists and Intensivists of Sri Lanka. And at this very important juncture in our day-to-day practice in anesthesia and intensive care, we are facing a huge crisis with the increasing number of COVID patients needing intensive care. And a lot of people actually need the doctors and nurses some idea about how to manage non-invasive ventilation, high flow nasal oxygen therapy, oxygen therapy. So we thought of updating you on these topics, and the Technomedics Private Limited has very kindly agreed to sponsor this webinar with their Indian counterparts. And for the first session, I would like to welcome Dr. Chandana Karunaratna, who is a consultant in anesthesia and intensive care, who is from Balapiti. Chandana, good evening to you.
Good evening.
Yeah, and he's not a stranger to the ventilation workshops and lectures in Sri Lanka. He's one of our very, very enthusiastic young consultant who has special interest in mechanical ventilation, various lung pathologies in critical ill patients, and he does get involved in postgraduate training on various aspects of artificial mechanical ventilation, troubleshooting of difficulties in ventilation. And he has been a very sought after resource person in many of our workshops and lectures at the college sessions. And now I would like to invite him for to update you on the non-invasive ventilation. Thank you, Chandana.
Good evening, everyone. I would like to thank Dr. Nilmini and the rest of the panel members for giving me an opportunity to talk on NIV in COVID-19. I think I don't need to explain what this pandemic did to the entire global health system. Even the richest countries were not prepared enough to deal with the pandemic because it was so rapid and so devastating. I think the whole world started doing whatever they can to contain the COVID pandemic, and we had basically respiratory problems. And because this predominant feature of the COVID infection, severe disease is hypoxia, people started using whatever the method they can to use to provide oxygen, from face mask to a high flow NIV to invasive ventilation with variable degrees of success. Now, before this COVID pandemic, we knew from our existing evidence, evidence based, that NIV is not the best option for hypoxemic respiratory failure or type 1 respiratory failure. We tend to avoid NIV in severe type 1 respiratory failure. And in addition, we had certain worries about droplet transmission with NIV. So initially, we were kind of reluctant to use non-invasive ventilation in COVID patients. But soon, ICU beds were all filled up, and there were no ICU beds for many, many patients. And then next thing closer to invasive ventilation is BiPAP, to give some kind of ventilation to a ill patient, not say. So, and then BiPAP compared to non-invasive ventilation is relatively or comparatively easy to manage by a non-trained or less skilled set of, we say, nurses and junior doctors. So use of NIV, and the other thing is NIV ventilators were kind of available in most of the medical wards and certain HDUs, things like that. So the use of NIV in COVID grew exponentially. Now we are in a desperate situation where we have limited options, limited facilities, and at the same time, we have limited evidence whether the NIV is actually helpful in type 1 respiratory failure. Yet we still have to use this modality of NIV in this pandemic. So we are not sure actually how good. So because we know that it's not proven to be very, very useful. So to get the best optimal benefit from the NIV, we really need to focus on when should we apply and when should we not apply NIV, and what exactly to expect from applying NIV. That is extremely important. Otherwise, we will just use NIV for the sake of using NIV in the some kind of guideline which is been changed or continuously. So let's first try to see what is actually happening in COVID to get an idea how to apply NIV in COVID. Now, first, as in many other viral infections, the coronavirus gets entry into the cells, basically the respiratory epithelium involving the alveolar cells. So they enter into the cell, they replicate, and then they destroy the cell, releasing certain kind of mediators. So this actually attracts the immune cells, and then our immune cells set up a certain kind of reaction to protect the body from the virus, and which is successful in majority of the patients. But in certain minority of patients, because of some reason which is not really clear at the moment, so there is some kind of dysregulated immune response. Generally, this actually involves so many mediators. I'm not going to details about the mediators, and then but interleukin 6 is one of the predominant mediator involved in this dysregulated immune response. These mediators actually set up a certain cascade of events in the body. Generally, it is supposed to protect the body, but because of this dysregulated immune response, so it leads to certain pathological process involved in the entire body, but basically the lung, the alveolar capillary membrane, and some vasculature. So this causes certain pathological process leading to hypoxemia. Now, this hypoxia, because of the what does the body do to overcome this problem is to generate a large tidal volume, so kind of vigorous breathing as a desperate measure to survive in this environment. So this actually causes further lung injury, and we call it actually self-induced lung injury. This is not specific to corona, so it can happen in, I mean, any pneumonia and viral pneumonia especially. So this actually complicates the matter, and then this thing goes on for some time, and then when we see some detectable respiratory failure, this is where actually using the parameters like saturation, blood gas values, work of breathing. So this is where we detect the problem. But it is extremely important to understand when you detect the problem, a certain degree of things, I mean, a lot of things has happened inside the body when we detect. So this is actually the crucial thing to understand. So when you want to manage a COVID patient or any other viral pneumonia patient, when you detect, if you just focus on the parameters which you use to detect the problem, so already a certain degree of damage has happened in the inside the body. So if you want to prevent further damage, you must focus on the pathological process as well as just trying to manage the type 1 respiratory failure is extremely important. So that is where we try to detect, but it's important to uh, focus mainly on the underlying process and what we can do to prevent the underlying process. Now, initially, so we'll look at COVID-19 and any ARDS for that matter. Um, so basically, ARDS has got some visible process happening and some kind of invisible process happening inside the body. What I mean by visible, invisible means basically we generally tend to, we are visual kind of creatures, so we tend to focus on what we can see, what we can perceive in our human eyes. So we see type 1 respiratory failure with changes in saturation, PO2 and PF ratios, all kinds of different parameters. But at the same time, there is some kind of damage happening inside the body. I mean, we know that as a matter of fact, there is something called volutrauma, atelectrauma, and there is biotrauma, multi-organ failure. We know that fact, but when you actually manage the patient, we basically focus on acute respiratory failure, but the most important pathway or the most determining pathway of the mortality is the biotrauma, multi-organ failure, and death. So if you basically concentrate only on the type 1 respiratory failure, it's important to focus on that one. But if you forget about that, the underlying process, then you will be then when you see the acute respiratory failure, something has happened already. So to prevent death, you must focus on the minimizing the release of mediators. Basically, the two main methods of volume and atopic trauma. So it's important to prevent those pathways if you want to save patients from this. So I'm using these theories to help you use the NIV appropriately. So I'm just going to discuss a little bit more. Now, two major causes of alveolar injury. There are so many causes of alveolar injury. So these actually release the mediators, as I told you. So that will drag the patient along the death pathway. So the two most important one is volume trauma, which is the stretch injury to the alveoli, and ROCA. We call it repetitive opening and closure of alveoli, or we can call it atelectroma. These are the two main reasons why we release a lot of mediators and leading to a lot of cytokine storms and everything in COVID. So what causes volume trauma? If I say it in one single answer, it's the excessive transpulmonary pressure. So what is transpulmonary pressure? It's a simple term to describe the pressure across the alveoli. So that is what determines the tidal volume, lung volume. So that is the main cause of volume trauma. So just in a little bit details, so that if I explain transpulmonary pressure, so I'm going to use two different patients who are exposed to same kind of external pressures. We say CPAP, and at the end of inspiration, the alveolar pressure will be that value, CPAP value, and patient is taking an effort of -5 centimeter water, kind of normal effort. So that generates a transpulmonary pressure, which is pressure across the alveoli, 5 minus 5, which is a +10 value. If you have positive value, you have a open alveoli, and here because of +10 value, you get 400 ml tidal volume, for example. But in the same time, the same pressure applied to another patient, but if the patient generates excessive pressures, excessive effort of breathing, then this patient generates -35, which generates, say, 900 ml of tidal volume with a positive 40 of, because 5 minus -35 is +40. Now, this is a very dangerous value. Now, this actually happens in real life, where you see people in early part of pneumonia in the ward. We don't usually see in ICU, people don't see them. But when you see them in wards, and sometimes initial couple of days in the ICU, you can see people taking very large tidal volume. We are very happy because the blood gases are perfect, saturation is perfect because they are taking large tidal volumes. But they are actually on the death pathway because they are damaging the alveoli, releasing mediators. They are going along the death path. This is the crucial point. We need to minimize the people going along the death pathway. And one thing as a fact is true, that is that if you have a large tidal volume, you always have large transpulmonary pressure. You always have lung injury. So it's quite important to control the tidal volume from the beginning if you want to save people's life from lung injuries. Now, as in any other viral illness, COVID virus causes sometimes alveolar injury, as I told you initially, and it causes certain degree of alveolar edema, like in any other viral illness. So it causes certain reduction in functional lung volume, what we call the baby lung, and then it causes hypoxemia. So this hypoxemia makes the patient, ask the patient to take vigorous inspiratory effort in some individuals, especially with the sometimes in L type, but you can see this COVID pneumonia. Anyway, so this high inspiratory effort will generate high transpulmonary pressures and even high tidal volumes, causing damage to the alveoli, adding more edema, so that it goes in a vicious circle, causing more severe. Now, the problem with NIV and with this type of injury, NIV is not a very good modality in at controlling patients' tidal volume, especially when they have extreme hypoxemia. The other people, you might give us some certain bit of sedation or some kind of opioids, but when you have extreme hypoxemia, it's not very good at controlling patients' tidal volumes. So the other method I told you is ROCA, or the repetitive opening and closure of alveoli. This is simply the alveoli getting closed at the end of exhalation because not enough adequate transpulmonary pressure or pressure inside the alveoli. So they close during exhalation and they reopen during inhalation. When it happens repetitively, so alveolar collapse and opening release a lot of mediators and you go along the death pathway. So you have to have a kind of optimal PEEP. If you have less PEEP, because of the alveolar collapse, it will worsen the ROCA. Or if you have more PEEP, it might even, I mean, you need to have an ideal PEEP, which nobody knows exactly. I mean, it's highly debatable subject. But if you have more PEEP, so it can cause over-distension of the baby lung, or the viable or the functional lung, and even it will compress the capillaries in that part of viable lung, and it will shift the blood from the ventilated area to the non-aerated regions, causing worsening of the ventilation perfusion mismatch. So, I mean, I can't give you an exact figure, but my suggestion is not to use extremely high PEEP unless it is really needed. And you have to always keep in mind that this can cause these kind of problems. And sometimes, I mean, it's much better to do permissive hyperatelectasis, what we call. I mean, you let this collapse alveoli collapse. Not a good idea if you don't know what you are doing. But I sometimes do this one to protect the patient, because if you concentrate more on mediator release and mortality, this is one thing you can do. But I don't think it's a good idea in COVID patients. But in other patients, we have tried that one, permissive atelectasis. So the whole idea is to prevent the mortality pathway or the multi-organ pathway, at the same time managing the respiratory failure to deliver just sufficient enough oxygen to survive. So how can you pick up this problem? So you can look at indicators of high transpulmonary pressures, if you want to see. So that is, for example, if you see large tidal volume, that generally means you have high transpulmonary pressure. Or if you can say other accessory information, like if you see a chest X-ray, expanded lung fields, then you have to consider probable volume trauma. And the other thing is, if the NIV is difficult to measure the transpulmonary pressure. I'm sorry, the plateau pressure and everything. So what you can do is, if you have a esophageal pressure monitor, if you see large pressure swings in the esophageal pressure monitor, that indicates the patient is generating high transpulmonary pressures. So patient is causing some kind of lung injury at the moment. So then you can intervene and do something about that. Okay. Now, so how do you minimize mediator release? It's kind of difficult thing, but the most important thing is to minimize the volume trauma. I mean, limiting the tidal volume. So one thing you can do is to figure out why the patient is taking that tidal volume. Maybe it's acidosis. If you correct the acidosis, probably it will help. If the patient is hypovolemic in acidosis, probably you can correct that one. Or correcting hypoxia may reduce that tidal volume. So it's important to correct that one. But if a intervention, for example, if you need to apply large tidal volumes to maintain certain oxygen level, for example, high oxygen level, like if you want to maintain above 96 saturation, and you need a lot of pressures to do that, then it's best to be happy with, lower your oxygenation targets. Generally, I generally manage in my ICU. I don't want any PO2 above 100. I usually keep the PO2 around 70 to 100. So it's a good idea to keep the saturation 70, so that you can actually minimize the amount of oxygen use, and you can minimize the tidal volumes and the lung injury, which can cause, minimize the PEEP to achieve those high targets. So minimize the oxygen target, just to allow the patient. So all what you have to do is to, I mean, virus will disappear. It won't stay in the body forever. I mean, it will be there for a week or two. Until that time, you have to manage the patient without killing the patient, without causing undue lung injury. Then you will be managing an ARDS from the second week onward. So you must make sure that you minimize the injury to the patient's lung. That is the key thing. And you should avoid excessive PEEP. So that kind of thing, you can minimize the mediator release. If you minimize mediator release, then you can actually save many lives. So ultimately, what we need to do is to minimize the release of mediators, at the same time provide sufficient oxygen. So oxygen delivery. So in this kind of pneumonia kind of situation, when the saturation is low, the body has got only three mechanisms in delivering oxygen: hemoglobin, saturation, and cardiac output. So body cannot increase hemoglobin instantly. So the only mechanism of the body to improve oxygen delivery is cardiac output. So this is ultimately extremely important when managing patients with respiratory condition, because some of the intervention, like PEEP application, if it reduces your urine output to zero, when you apply high amount of PEEP just to recruit all those alveoli, you are just actually doing more harm than doing good when it comes to oxygen delivery. So it's extremely important to make sure that you maintain cardiac output when you intervene in respiratory therapies. So NIV, basically there are two main flavors, CPAP and BiPAP. CPAP is what we call continuous airway pressure, positive airway pressure. So we use a specific CPAP mask, tight fitting face specific CPAP mask to apply CPAP. And what it does is, usually when we breathe, so this continuous positive airway pressure is applied to the airway, so that augments the inspiration. So it allows the patient to take a better breath, and at the same time it keeps the lung inflated, increasing the functional residual capacity, and it basically improves oxygenation. So it's a very good way of oxygenating a person. But when you try to exhale, so this pressure can actually hinder the exhalation process. So it's not ideally a good method when you need CO2 clearance. I mean, if the patient has got enough muscle power, they will clear out carbon dioxide, because the brain activates all the pathways to clear out carbon dioxide. But it's not ideal for CO2 clearance, but it's good for a what we call oxygenation, because it has this CO2 problem. Then the people develop what we call BiPAP, that actually allowed, so that changed the pressure, so it actually dropped the pressure when the patient want to exhale, so that it allow easing the exhalation also. Basically it's kind of two pressures. So you are basically on the EPAP level, or what is called baseline level. So if you use a conventional ventilator, that is your P for CPAP, the same thing. So we have a different name in dedicated BiPAP devices, EPAP. So what it does is, as I said, it recruits the smaller airways and improve FRC. It has got its own benefits. But whatever it is, when the patient tries to breathe, the BiPAP ventilator senses the patient breath, and at this instantly it will get the pressure up. So this way it assists inspiration, and we call it a pressure support in a conventional ventilator. But in BiPAP dedicated, we say it's the difference between IPAP and EPAP. IPAP is inspiratory positive airway pressure. EPAP is expiratory positive airway pressure. Now, this gap is what we use to improve ventilation, because if you have a larger gap, then you get large breath. Likewise, if you have more EPAP, you have more lung volume, more positive pressure, and more oxygenation. You have more gap. It's important for ventilation. So when the patient tries to exhale, it instantly drops the pressure back to baseline pressure. So that itself is exhaling, and it helps the exhalation. So it helps unloads the inspiratory muscle and expiratory muscle. It very well improve work of breathing in many patients, and it's good for carbon dioxide clearance, because it causes ventilation, and it's good for oxygenation, because you can adjust the EPAP or CPAP or PEEP or whatever the same name. You can adjust that baseline pressure to improve oxygenation. So that is a good way of managing patient. Generally, in BiPAP, you get each and every breath supported like this, when the patient is breathing spontaneously. But it's important to know that most of the BiPAP ventilators, they are basically by default, they are in a mode called ST mode. ST mode is what we call spontaneous timed. So basically, if the patient is breathing spontaneously, so it will be a normal BiPAP. You get pressure going up with the inspiration, coming down with exhalation, and allowing patient to breathe easily. And it's a very useful method. But this is actually because these devices, what we use in Sri Lanka and most of the developing countries, they are actually domestic devices designed for to be used in domestic environment. So if the patient, somebody is having some kind of sleep apnea syndrome, and if they become apneic, so the ventilator needs to deliver some breaths. That is why we have a timed breath. So basically, BiPAP ventilators are in this mode by default. Most of the ventilators, so you can set a certain rate. So when the patient is not breathing, you get this timed breaths, like a CMV or SIMV kind of breath, which has got a certain time period, which is determined by us, the person who operate the machine. We initially set these time intervals, and you continue. So basically, I don't like this ST mode, but because I need when the patient is becoming apneic, I need to be notified. But this actually, the ventilator will function continuously, giving sort of breaths, but it's helpful in domestic environment. But if I can, omit out ST mode, I would just use normal BiPAP mode, so that I will be alarmed. I will get some alarms when the patient is becoming apneic. I can intervene and do something. I don't want the unconscious patient on a BiPAP. Anyway, So that is what BiPAP does. So what is the advantage of NIV in COVID patients? As we know that the expertise, I mean, we need a lot of expertise to manage invasive mechanical ventilation, and you need to have a lot of skilled people. NIV is easy to learn, easy to apply, and if you remove it, you can just reapply, not like an intubated patient. If you extubate and it's a big problem to re-intubate, and these devices are available in most non-ICU environment. I mean, in Sri Lanka, I think it's each and every medical ward we have at least one device, BiPAP device, and it's easy to work when you compare with the high flow nasal cannula or face mask or a venturi mask. So this has got ability to augment or escalate both ventilation and oxygenation, because you can change the IPAP or the pressure support to allow more ventilation, and you can adjust the PEEP to allow more oxygenation, things like that. And potentially it can save a lot of oxygen, because this device, BiPAP devices, you need high flow only during inspiration. Exhalation, you have a moderate or low flow just to maintain pressure. Whereas in high flow nasal cannula, you have continuous flow whether you are breathing that oxygen or not. So there you can save some amount of oxygen if you use NIV. That's an advantage. Now, in invasive ventilation, of course, it's a completely tightly closed system. So you can't have free air if you want to breathe. A patient cannot breathe free air because the ventilator has to open the valve and give them gases. So it's kind of a limited. So patient does not have the liberty to breathe the way they want, unless the person who operate knows how the patient is behaving and how to handle the ventilator likewise. So it's not a very good way in when it comes to freedom of breathing. But NIV has got a lot of freedom of breathing, because if even if you do a big blunder, so patient can at least take some gases because of leaks around the mask. They can exhale, so there is minimal in asynchrony with the NIV, and because it has got some intentional and unintentional leaks, so you have this problem of leakage of aerosolized material. So you have to be careful when you are using NIV in COVID. So you have to do everything possible to minimize that one. So we'll talk about that one later. But what kind of devices can we use to provide NIV? So the ideal thing is to use dedicated NIV devices like um, ICU type NIVs, but it's not widely available and it's hardly you can find it. But some countries they have enough devices like that. But we have standard ICU ventilators. Some of them have a dedicated NIV mode, but even if you don't have one, you can still use if it has a CPAP pressure support mode, and if it can provide a lot of flow to compensate for the leaks. But if you have a dedicated one, they have certain alarm settings and certain settings to optimize the sensing and everything. But technically you can use any ventilator which has got a CPAP pressure support mode and has got enough flow generating ability. Uh, so you can use as an NIV device. But most of the time we use what we call portable NIV devices, which are not basically designed for ICU hypoxic patients. So for example, so this is one kind of device we have in Sri Lanka, widely available in wards and everywhere. This is basically designed for non-high, like type 2 kind of respiratory failure patient. This is an extremely good ventilator in that aspect. But when it comes to providing oxygen, we connect this to a 15 liter minute say flow meter, the wall oxygen, or even even cylinder oxygen. We use 15 liter. That is the flow connection to the ventilator. Now 15 liter. So if you use, for God's sake, use the maximum flow 15 liter. Don't ever use low flows in hypoxic patients, because they need a lot of oxygen to breathe, to survive. For example, if you take a normal bed tidal breath, so generally you need about 30 to 45 liters. Minimum is 30 liters for the normal average tidal breath. So during the peak inspiration, that is where you get a lot of gases into the lung. So if the machine cannot provide enough oxygen, then you can't provide enough. So you can provide the pressure support, but you cannot provide, because the ventilator will generate, recruit some air from the atmosphere and pressurize and get the pressure support. But oxygenation during the inspiration is not really optimal. The FiO2 is not really optimal. But suppose the patient is having acute respiratory failure, maybe their flow rate is inspiratory flow, peak flow maybe 60, maybe even 100. So how can a 15-liter oxygen flow can deliver oxygen into a patient's lung who is extremely hypoxic? It's not possible with the usual these domestic devices, but it's good for type 2 respiratory failure. But you can give oxygen, but it's not ideal in acute respiratory. We have to be mindful about this one. So if you really want to do this, you can either, so you can actually attach two flow meters, and this is actually a picture of 15-liter flow meter. So you get 30 liters. There's some kind of help, but if you can provide if you can get two 25-liter ones and can combine them together, probably you can, but it's not widely available. And these days, even the normal flow meters are difficult to find because of the pandemic worldwide. Now, other thing is you can make a custom-made connectors to pipeline oxygen, and then you can use whatever but I don't know whether these devices or not all devices can be connected to the pipeline. Somebody has to do that change. And there are newer devices with single limb acting as oxygen reservoir, but they are not widely available. I have seen certain devices which can actually provide higher oxygen, but it's not widely available. I don't have enough time to explain that one. Anyway, so devices connected to pipelines. If the whole oxygen, then basically the standard ICU ventilators, dedicated BiPAP ventilators, they can provide whatever the oxygen flows, if the ventilator can handle that flow. So most of the time, like the Newport ventilator, that can handle 110, something like that. Some of the devices can handle, like Philips devices, the BiPAP Vision, the oldest one, they can handle 240 liters, because you have to compensate for leaks in NIV. And then so with the tight fitting, properly fitting face mask, you can provide 100% oxygen easily with the dedicated ones or with devices connected to pipelines. Now, just because you have NIV and you are trying according to the guideline, if you don't have a proper mask fit, you are not actually giving good NIV. So most people think the tighter straps is going to cause better seal, but if you tighten the top straps, you might get leaks from lower down. If you tighten the lower one, you might get leaks from top. So what we actually need is more uniform pressure. It's extremely important. Otherwise, most people do not like this one. I mean, people try to tighten the mask so hard. So you have to educate the nurses, especially not to tighten is too tight. I mean, just tighten is enough, so that, but you have to have uniform pressure around the face mask. And selection of the mask, correct size mask, is very important. Otherwise, you get leaks all over the place, and you have danger of getting COVID from these patients. And it's extremely important to explain the patient and counsel the importance of keeping this mask on their face. Otherwise, if they deteriorate and if they want to, I mean, if we want, get a, I mean, if we want to intubate them, then that is a more risky thing. So when you explain that, probably most of the patient, they are happy to comply with the mask and breathe with the mask. Okay, so no proper seal, no proper NIV effect. So how do you know that there is a proper seal? That is a big problem. I mean, people people think because the ventilator is working and the patient mask is on, there are no audible leaks. People think the NIV is working. And if you try to hear for noises and it's a bad one, actually, I can show you a certain example where there is no noise, but there is a big leak. And some people use inspiratory tidal volume differences, but basically you have leaks in NIV that is inherent to the NIV. So this may not be a good option, but still you can say, I mean, if you have big difference in inspired and expired tidal volumes, then probably you can say there is a big leak. But one important thing is looking at the ventilator graphics, not the pressure volume loop. I mean, you can use that one also, but much more simpler ones, like, which is available in any uh, kind of standard ventilator. You have pressure tracing and flow tracing. Now here's an example, one of my patient in my ICU, where when I came, so I saw the graph and there was no audible leak, but you can see that the top one is the pressure, the bottom one is the flow. Flow is what we call a vector variable. It has got a direction and a magnitude. So anything above this line over here is towards the patient. Below the line is away from the patient. So I can't see anything below the line. That means I don't see any exhale gases coming. So exhale gas is not coming because everything is leaking from the mask. So this is a good example of detecting a large air leak but it looks like the pressure goes up and down and patient is breathing, and you might think, I mean, you have attached, I mean, set the parameters properly, okay, but you can see the tidal volume is 0 over here, because the volume is not coming through the uh, expected line, because there is significant leak. So I'm going to show you one example. I don't know whether this video is you can see. So this is one of my patients. When I try to see in the ventilator, you can see only a very tiny bit of exhalation waveform, very tiny exhalation waveform, because there is a significant leak, and you can see the tidal volume is only around 200 something. So I can't hear any audible noise, but there is a big leak. So what I did was I just corrected the mask a little bit. Just tiny correction is enough. And then you can see a significant exhalation, but still not ideal, but you can see some amount of better exhalation waveform. But you can see a good, better tidal volume of 400 something. So just by adjusting the mask a little bit. So it's very, very important to educate the nurses to identify the mask leak using the exhalation flow waveform. It's extremely important. So it's easy to detect. If you don't see exhalation waveform, readjust the mask. Otherwise, you are also at danger of getting all these aerosols from the mouth. And then other thing is, it's you don't get enough um, NIV effect if you don't have a good mask seal. Okay. So it comes in single limb devices and dual limb devices. And basically, these single limb devices were designed to be used in the domestic environment because they are less bulky. When these people are basically on this mask every day when they sleep, or sometimes when they even during daytime. So when you move around, it's quite difficult when you have a two limbs. So that is why they initially developed a single limb circuit with so if you have single limb, you only get inspiratory air coming from single limb. You have to have some other way of exhalation. Basically, you have some kind of vents in the mask. I don't know whether you can see. You have certain holes in the mask or somewhere in the tubing to allow the patient to exhale. It's so it's but it's when it comes to droplet spread, this is a bad device because you cannot simply close all the holes, and it's not a very good or ideal device to be used in COVID situation. Whereas in dual limb circuit, where most of the dual limb, you use it with a non-vented kind of closed mask where there are no holes, and then you have a separate limb for exhalation, and you exhale through the exhale limb. So this way you avoid, or I mean you minimize, not avoid. You can minimize the aerosol exposure because patient is actually using the exhalation port. You can have a valve over there and over here also, to minimize the exposure to COVID. So NIV masks, there are so many types of NIV masks. I'm not going to waste my time explaining everything. And I basically try to explain this mask in the middle, which is the oronasal mask. This one is full face mask, which is not widely available, and there's no point talking about that one. And this is the helmet mask, which is supposed to be better in prevention of spread of the disease in case of healthcare workers, because it's kind of more sealed. But it's not widely available in our country, so I will just omit that one. So this is the oral nasal mask. So it comes in vented mask, two different formats. Vented mask, where you have certain degree of holes in the mask, so the exhalation, and usually used with a single limb, and usually not ideal in COVID setup because it like a jet, you get air, jets of air coming from these holes. And you must almost always use non-vented mask in COVID situation. Non-vented masks are usually used with the dual limbs because you use the exhalation valve on the ventilator. So the patient exhales through the exhalation limb onto the ventilator, and from there it goes out. You can just simply put a valve, filter there to filter that one. Or if you have a single limb, if you use non-vented mask, then you have to find some way of exhalation. Basically, you can have exhalation port, or you can have a hole or something like that. So these are the two main types of um, NIV devices. These are the vented masks, which has a lot of holes, and this is an unvented mask where there are no holes. So if you get a close up in the vented mask, you have so many holes, and you can have either one big hole in the as a expiratory port, or you can have many holes in the mask for exhalation. So if you want to use an unvented mask, you must always attach the viral filter over here, so that when you exhale, so exhalation port is over here. I don't know if you can see there's a tiny port over here that's called exhalation port. An additional thing, you can have a single hole as a port, or you can have slits as exhalation. So these devices are, I mean, these ports are sometimes it's difficult to find nowadays because of the increased demand. So you can have a dedicated, I mean, you can improvise some kind of hole in your this thing, but you have to be careful. It should be a certain size, which I can't remember the exact size. You can find it on the internet. So you can actually make your tubing compatible with your non-vented mask if you don't have these ports. But make sure get the proper size. Otherwise, if it is too small, patient can't exhale. If it's too big, the ventilator cannot generate enough pressure. So anyway, so this is how you use an unvented mask with a single limb circuit. And if you look at the infection transmission risk with the NIV, I mean, people have tested this before the COVID thing came up, especially with the previous SARS episode, and they found out the droplets usually they don't travel more than 1 meter. That's actually how actually people came up with probably 1 meter distance. So these droplets don't travel even with the NIV mask. So more than 1 meter. So they said in the SARS epidemic in the first one, the NIV was not a significant contributor factor, but we don't know with the new one, so we have to always be careful. So always to provide or minimize the exposure or to prevent the exposure, you must always get a good fit. The correct size of mask is important, and you always use non-vented mask and add a viral or bacterial filter between the mask and the exhalation port. And if sometimes these masks contain certain holes for gas analysis and to provide some oxygen. So if there are holes, close all these holes when you use even in vented, non-vented mask, you can have a hole. So you make sure that you close that one, otherwise you get a jet of air coming through that hole. And you use dual limb, you must use dual limb circuit as much as possible. Helmets, as I told you, less leaks and kind of protect you. And you have to use all the other general measures like PPEs, N95s, everything. And especially when you set up the device before you connect the patient to the NIV device, I mean, it's very common when you connect the mask to the YPs or the ventilator to the mask, you get so much of air because the ventilator will try to push air, very high flow of air, so that will disperse a lot of aerosols. So it's extremely dangerous to connect a BiPAP machine over in case ventilator or BiPAP machine to the mask because it generates a lot of aerosols. What you have to do is first you have to set up the NIV and put on standby if possible, or else switch it off. And if you can switch it on, and then instantly, if you can get the settings properly, then basically you set up the NIV and put standby, and then you attach a viral bacterial filter before you place the mask on the patient's face, and then you connect the patient mask filter interface to the NIV circuit, and then quickly do it, and then only you turn the ventilator so that you ensure the good fit, and then you turn the ventilator on to minimize exposure. So okay, there are certain criteria for NIV initiation. I'm not going to go into details, but basically we don't know exactly what to, because we know that NIV is not really helpful in hypoxic respiratory failure, but we are using it. So whatever the indications and everything we are just now using, maybe they are not really accurate. We have in accurate terms. Anyway, so whatever happens, so if the patient wasn't on face mask or whatever the other methods we use to provide oxygen, so that is the indication. So in different, you have to actually refer to your own institutional guidelines. So I'm just giving a rough guide of it. Maybe if the patient needs more than 40% oxygen to maintain saturation less than 92, probably you will have to use NIV. You can try, but you have to always you know have a plan before you do that. And if there is features of work of breathing, this is extremely important. As I told you, if you allow the patient to take very large tidal volume and you don't correct the hypoxemia and all the problems work of breathing, then they will have more damage and multi-organ failure. So you have to sort out the work of breathing you can look at the accessory muscle use, especially the neck muscles. Uh, and so that is how there are so many parameters uh, to use NIV in a COVID patient. Most of the time, when the patient is not improving with the oxygen mask, and that is how you, it is the kind of indication. So before you apply, you have to rule out the contraindications, especially the pneumothorax, severe hemodynamic instabilities. So there are so many contraindications. I mean, I'm not going to details. So you rule out contraindications and you get some kind of baseline status to see whether there is an improvement. If you don't get a baseline status, then you don't know whether the patient improved or worsened on NIV. So you can either do a blood gas or you can use whatever the methods you use, like say PF ratios, SF ratios, or any kind of method you can use as a baseline depending on your institution and guideline. And you have to always have a escalation plan and exit criteria. When are we going to escalate, or are we going to have a ceiling of care? We kind of, you don't intubate this patient and stop at that point, or whether you go into full escalation. You have to have a plan before you apply NIV. And when should I stop NIV? Basically you just look for worsening of NIV, worsening of the lung condition, all these ratios and everything, say work of breathing. You can look at various parameters and make your own guideline to decide that the patient. But the problem with the current pandemic is, even if you try to decide to intubate, and there are no places in ICU beds to send this patient. So even though the guidelines say sometimes we may have to keep this patient on NIV for a longer duration. Anyway, so how would you escalate the patient? So if the saturation is low, you can adjust the FiO2 or readjust the EPAP or PEEP or CPAP, whatever the one displayed in your ventilator, and then you can adjust that one. And you can always check the oxygen supply for any kind of fault. There are so many other things you can do in low oxygen status. But for example, if the patient is having increased work of breathing, even on this thing, you can actually adjust, keep on adjusting pressure support, but there should be a limit. I mean, you can't be increasing up to the maximum pressure support available in the ventilator. I mean, so you have to have a certain limit, and then you got decide, okay, if the patient is not improving, rather than waiting too long, letting the patient damage all the alveoli and go in the death pathway, then you have to make a decision. You have to reassess always, because we know that, I mean, NIV is not that effective, but we don't have ICU beds. So, but you have to figure out where we should exit the NIV. Some people actually improve, especially with good hands. I mean, so NIV and invasive ventilation, because we use the same ventilator and same pressures, so it can't be the device. So it has to be something, the way we apply. If we get a good seal, probably we can do a much better job. I mean, if you are experienced with NIV, probably you can aim closer to invasive ventilation, and you have added advantages also. But in certain hands, NIV is kind of dangerous if you don't know what you are doing, especially if you don't know how to ensure a proper seal and proper settings. Anyway, you have to reassess the need to extend the NIV for intubation, because if you delay the intubation in most of these individuals, so that can increase the mortality. And one thing we can do to improve the outcome is, and improve the oxygenation, is awake proning. I mean, there are certain guidelines. Some people say 16 hours a day. Some people say 3, 4 sessions 3 to 4 times, something like that. So some people keep on yourself, turning to side positioning. You can do various stuff, whatever it is. If you look at the lung of a person who is lying supine, and if you divide right in the middle like this on horizontally, you can see bulk of the lung is actually on the dependent part, or the dorsal part of the lung. So if there is any problem happening in the ARDS lung, so this fluid deposition, X-ray deposition, everything happens in the bulk part, or the big part of the lung. And here, because the if you look at the lower part of the lung has got a lot of muscles in it, and it's quite thick, and the alveoli are kind of so it's a kind of higher pressure outside, but compared to the thin chest wall in the anterior wall, so the transpalm pressures, when you apply the same pressure, so here outside pressure is slightly larger because of the gravity of the lung and the height of the lung and the muscles and everything. So these alveoli are not exposed to high transpalm pressures, but they actually expose to low transpalm pressures, and they can collapse. But the top alveoli, because they are in a kind of relatively lower pressures outside, so they can have over distension of the alveoli, So here you can continue to have lung injury at the same time collapse alveoli at the dorsal part. But if you put the patient prone, even if you get some kind of exudates, you're actually collecting in the smaller part of the lung, and you have a big part of the lung to maintain your gas exchange. And at the same time, when you put the patient prone, the weight of the spine and the muscles will protect these lungs because of the outside pressure, and you have some external pressure outside, so it will protect the bottom lungs also, alveoli also, and you get better VQ and everything when you put the patient prone. So you can ask the patient, conscious patient, to have the mask, and it's sometimes difficult. Some positions, some patients will not tolerate, but you try to turn the position here and there and try to keep the patient prone as much as possible. When you have a problem in oxygenation and where there are no options, then awake proning is a good kind of thing. As I told you, the NIV, because the patient has got liberty of breathing without having a lot of asynchronous issues. So sedation is not generally. I don't usually. I mean, I can't remember anyone's. I sedated for NIV, but generally it's not required. But some people, they, because they don't take time to explain the patient. So patient is getting this high flow of gases onto his face, and they are anxious. So some people do not tolerate NIV simply because of that. So explanation is better than giving benzodiazepine. I always tell my juniors, because that is very important. I mean, if you sedate the patient, especially by giving a benzodiazepine in a non-ICU setup, like in a wards, may have a disastrous consequence. It's a very, very bad thing to give midazolam simply in a non-ICU environment just to settle down the patient. You have to always first try um, explaining the patient and explaining the importance of keeping the NIV. And you can give a small dose of opioids. And I have seen when you give especially subcut morphine, especially in COPD patients, they tend to tolerate the mask better. Maybe it's analgesic, maybe euphoric, I don't know exactly. If you want to give a drug to sedate, dexmedetomidine has got no significant respiratory depression, but it's not available. I have never used that one in my life. So people say that NIV, when the NIV fails, it is high mortality. Why do you think it goes? We don't never knows why, but maybe it's because we don't read the underlying problem. We just keep the patient on NIV. We don't switch it when the NIV is just a bridge, bridge of therapy until you sort out the underlying issue. Until the patient comes out of COVID pneumonia, you have to maintain their life. You have to provide sufficient oxygen delivery without damaging the lung. Without damaging the lung, like intentional damaging, that is the key thing. So you just give the NIV, you just provide NIV, you just see whether you can do that. If you can't do that, if the NIV is not indicated or if it is not working, early switching to other alternatives is the best option. So NIV is useful. You have to always know how to use the tool. So don't blame the tool. NIV is useful, Hfno is useful, face masks are useful. It's only us, we just use it on, say, useless. Sometimes we don't have other options, but you have to decide when to use and when not to use. So as a summary, I want to say focus on the patient, not on the NIV device. So NIV, as I told, is not a specific treatment for any particular disease. So when the underlying disease improves, the patient improve. But if you intervene and do some lung injury or ventilator-induced lung injury and invasive ventilation or some kind of lung injury because of NIV, then you have another ARDS to manage. And of course, most of the ARDS we manage in our setup is actually some, in a way, ventilator-induced lung injury, because we patient gets a lot of lung injury. So we have to pay particular attention to mechanisms of lung injury to avoid worsening of the condition due to biotrauma. So that is what drags the patient along the death pathway, and frequent assessment is needed to evaluate further continuation or discontinuation of NIV, because we know that NIV is not the ideal thing in the hypoxemic respiratory failure. And early intubation kind of important, is of paramount importance when the NIV is failing. And because there is not enough ICU facilities, although we tell everything, we may need to modify our guideline at a certain point if the pandemic evolves in a bad way. So we may have to keep these patients more on NIV because we are not having enough ICU facilities. I hope you got some kind of, what I really wanted in this lecture is not to give you a certain set of guidelines, But to understand what is happening with the COVID and any other viral pneumonia for that matter, and they understand the importance of detecting the ongoing process. I mean, when you see the problem, things have happened. So you to save the patient, if you just focus on the parameter you just figured out the patient is having this respiratory failure, that is too late. So you have to manage that. That is true. But unless you manage focus on, if your focus is on hypoxia, improving oxygenation, then you are missing the death path. So that is the primary thing if you want to save. That is the only message I want to tell you with NIV. So don't focus on the NIV device. So use it's just a tool. You just use the NIV, the beneficial points or the uses of NIV to help the patient go through this menace, go through this illness and save that patient life until the nature or the immune system heals the problem. You don't do excess damage. That is what I want you to have. You just save the patient life until the nature or the immune system saves the patient. Thank you. That's
Thank
all.
you, Chandana. Thank you very much. And I think Chandana gave a very good insight into how to use NIV. And Chandana is not only a good clinician teaching ventilation, he is also an sort of an engineer. We out of the anesthetist who has invented a locally made ventilator also. So his passion is really amazing. Thank you, Chandana. I think we'll keep the questions to the panel at the end so that we can mix and match whatever the questions have come up. So now I would like to invite our next speaker, who is going to talk to you about high flow nasal oxygen, continued importance use in COVID-19. And this is Dr. P. Vivekanathan. He's basically a trained anesthetist who has a passion for intensive care, who has moved to become an intensivist with his qualifications beginning with the fellowship in anesthesia and then FICUM and EDIC. And he's a well-known teacher and a trainer in critical care. He works at the Medical Royal Care Super Specialty Hospital in Coimbatore, India. And for to be the moderator for this session, I would like to invite Dr. M.N. Sivakumar, who is the head of the Department of Critical Care at the same hospital. And he is also a outreach program, ICU Connect, to train inventor. And he has a special interest and does a lot of teaching in critical care. And this outreach program, which is called ICU Connect, has trained a lot of critical care paramedics in small and bigger hospitals as well. So over to you, Dr. Sivakumar, to conduct and be the chairperson for this session. Thank you very much, and thank you again for coming, agreeing to do this session to update our local participants on this very important matter at this time. Thank you.
Thank you, madam. Thank you for your kind words. Am I audible to you?
Yes, please.
Yeah. Okay. Greetings from Coimbatore and from my institution, Royal Care Super Specialty Hospital. At the outset, I would like to thank Fisher and Paykel and the Sri Lankan Intensive Care Society for this opportunity. And also, I would like to congratulate Fisher and Paykel for organizing such a useful CME at this point of time. We in Coimbatore are yet to reach the peak of pandemic. Our daily case average is close to 4,000 mark in the last few days. And I do check at the numbers in Sri Lanka, and you're also going through a similar kind of picture and an intense lockdown and a lot of travel restrictions. And I wish and pray and hope that we all come out of this pandemic in a very, very safe manner. With these few words, I would pass it on to my colleague and good friend, Dr. Vivekanathan, who would be talking on the importance of high flow nasal cannula and with particular focus to the usage in COVID-19 patients. Dr. Vivek has been already introduced by Madam, so we would straight away go ahead with the lecture. Thank you.
Thank you. Good evening, one and all. It is a pleasure to be giving this talk. I thank the organizers and the chairperson and the moderator for the same. The topic is high frequency nasal cannula, continued importance and use in COVID-19. First of all, at the outset, I would like to thank my colleagues and Dr. M.N. Shivkumar from the Institute of Critical Care Medicine at the Royal Care Super Specialty Hospital from Coimbatore. My talk would have an overview with what is high frequency nasal cannula, some of the aspects to it, what is the role of high frequency nasal cannula in critical care, and has it got a role, and what would be the role in COVID-19? And most importantly, how would you predict failure having instituted high frequency nasal cannula in COVID-19 patients? And a few slides to share our experiences as well. So basically, I don't think it is intricate as such that high flow nasal cannula setup or delivery or management of patients on high flow as such. If you look at it, it just has a flow meter, oxygen and air blender with an active humidifier delivering through a single heated inspiratory circuit through a interface, which is a nasal cannula, which can be easily applied. The most important aspect to high frequency nasal cannula is its ability to deliver a fixed oxygen, and at the same time it can deliver very high levels of flow. So that is a key element of high frequency nasal cannula. If you were to look at the different aspects of oxygen delivery devices, we very well know that there are variable devices which don't have a fixed amount of oxygen that's being delivered. Examples would be the nasal cannula, because of the entrainment of the air that tends to happen. And of these, the oxymizer device can have a reservoir and can deliver a higher level of oxygen. But the high flow nasal cannula and the Venturi mask are the only two fixed delivery devices which can give a fixed percentage of oxygen, whatever is being dialed or the flow is being set at. So it is very important to note that point, that it is a fixed oxygen delivery device at the dialed flow. So we do have a spectrum of respiratory support, be it just oxygen delivery with a nasal cannula or a face mask. And later on, it could be a high flow nasal cannula or a NIV, which has been very well touched upon in the previous lecture, and going on to invasive ventilation per se. But CPAP is one of the options that's available, which has not been very well undertaken. So with a more emphasis on high flow nasal cannula, it has got its own area of niche in managing COVID-19 patients. So the essence of high frequency nasal cannula comes here, where if there is a peak inspiratory flow that is happening and the patient is out of breath, they are taking more than the normal tidal volume. And if you were to deliver with a variable device, likewise the face mask, which is running at 10 liters of oxygen, then during the peak inspiratory flow, there is entrainment of air, and the amount of oxygen that's being delivered will be diluted by the entrained air. But whereas in high flow oxygen, the whole of the inspiratory flow will be matched, be it at a rate of 35 liters per minute of inspiratory peak inspiratory flow in a normal adult, or be it in a really bad COVID-19 patient. You've got tachypnic, high large volume generating patient. You've got a peak flow of up to 60 liters. Still, if the high frequency flow has been set at 60 liters, it will deliver at the percentage of oxygen that is being dialed at. So it will deliver to the demand, the flow will be appropriate, and the percentage of oxygen dialed will be delivered without any dilution. What else can it do? It can reduce the amount of carbon dioxide in the exhaled air. And if you look at the slide where there is a dialed in flow of around 15 liters, the upper airways in the pharynx, it can be cleared of the CO2. And if the flow were to be increased at, say, for example, 45 liters per minute, then it can clear the carbon dioxide even up to the major airways as well. So there is, to a certain level, that carbon dioxide clearance happens with high flow as well. If you were to look at the PEEP effect that can be achieved with high frequency nasal cannula, if the mouth were to be open, then the amount of PEEP effect it delivers is lower. If we advise the patients to keep the mouth closed most of the time, then the amount of PEEP that is exerted can very well be in the tune of 0.5 to 1 centimeter of water for every 10 liters of flow. So that will be around 0.5 to 1 centimeter of water every 10 liter of flow that is being increased. So you could very well achieve a PEEP of up to 4 centimeters of water. That's not bad. That's not bad. That is the same thing depicted in the nasopharyngeal pressure monitoring, where with a higher flow, you could reach a PEEP of even up to 4. What else can it do? It can very well maintain the humidity. And very well we know that humidity, if it is not being delivered, even for 15 minutes or so, then there is a mucosal damage that tends to happen. And then the secretions are being retained and the effective clearance of secretions may not be possible. So looking at this forest plot, you could very well see that the patient complaints and the patient comfort level, the dyspnea, effective secretion clearance is all better with humidification that's being very well done with a high frequency nasal cannula. In a nutshell, what all high frequency nasal cannula can very well do: the humidification is very well maintained. It can wash out the dead space. The anatomical dead space can be washed out of carbon dioxide levels. And it does have a high nasal inspiratory flow, reducing the resistance and increasing the compliance. Thereby, the work of breathing can be reduced. Very well with a increasing PEEP, albeit it is at a lower level, it can cause reasonable recruitment to the atelectatic lungs and improving the ventilation perfusion mismatch as well. And the entrainment of air can be very well reduced, delivering a fixed oxygen level that has been dialed. So all these things are potentially achievable with a high flow nasal cannula. So there is a superior comfort and the reduced work of breathing. And the key point I wanted to emphasize is better secretion clearance that can very well happen as against NAV. So if you were to initiate high flow nasal cannula, most important thing is the patient needs to be explained very well what we are trying to do and what we are trying to achieve. So explain the intervention and then probably start at a lower flow of around 30 liters or 40 liters per minute. And then ensure that the tubing is very well placed. There is no interference with the nasal cannula that is being delivering to the patient. And the FiO2, as per the patient, it has to be individualized. It could very well be at 30% or be it 80% as per the need of the patient. Targeting a saturation these days to around 92% will be adequate. And then encourage nasal breathing with a closed mouth. As we saw in the previous slides, the PEEP effect will be much more better. And then the flow can be increased in increments of 5 liters per minute based on the patient need and comfort. While you're looking at weaning of NAV, the high flow nasal cannula, you would rather look at reducing the FiO2 first and then the amount of flow that is being delivered. So I think this is in essence how it is initiated, and later on at the weaning phase, you're trying to reduce the FiO2 and then reducing the flow. So this is in brief about high frequency nasal cannula. And of course, before initiation, you would rule out any contraindications that might be present. So we will briefly look at what are the wider roles of high-frequency nasal cannula that you can see in critical care. So I have summarized them briefly out here. That it has got a significant role in acute hypoxemic respiratory failure, typically the COVID-19 in the current situation. Post-extubation, you're trying to prevent re-intubation, cardiogenic pulmonary edema, obese critically ill individuals, palliative care, prior to endotracheal intubation, trying to achieve pre-oxygenation, COPD patients, and during bronchoscopy as well. So let's look at the role of high-frequency nasal cannula in acute hypoxemic respiratory failure. The landmark trial is the Florally one, which was done in 2015. It was conducted across 23 French ICUs, and they did compare high-frequency nasal cannula, non-invasive ventilation, and conventional oxygen therapy, COT, conventional oxygen therapy in acute hypoxemic respiratory failure. What did they want to do? The primary outcome was, did it prevent intubation in those patients? The secondary mortality outcome was also looked at 90 days of care. So the key things that I wanted to point out in this slide is the intubation. So the number of intubation in high frequency nasal cannula, the top one, where what was observed was around 38%. Whereas in NIV, it was up to 50%. And in the conventional oxygen therapy, it was nearly 50% as well. So there was a reduced incidence of intubation by day 28 among the high flow nasal cannula group. Looking at the mortality again, it was 12% with high flow nasal cannula, whereas it was 28% in NIV, and conventional oxygen therapy was 21%. Mortality at 90 days was around 13% with high flow, whereas it was 32 and 27 with NIV and conventional oxygen therapy. Ventilatory free days was definitely lower with a high flow cannula usage. The results did say that high flow nasal cannula was non-inferior, or in fact better than conventional oxygen therapy, and definitely not inferior to NIV in subsequent need for intubation and ventilation of those patients. And high frequency nasal cannula reduced the mortality at ICU and also at 90 days. But it was not powered enough to have a significance of this observation, and definitely did reduce the patient comfort and dyspnea. Some of the weaknesses to note: majority of the patients had pneumonia, and at that time in 2015, they resorted to observing that they had acute lung injury instead of the more common definition of ARDS. And the duration of NIV that was spent in the NIV group was less than 4 hours in 25% of those group of patients. So those were some of the weaknesses observed in this landmark trial. There was a post-hoc observation that there was a lower rate of intubation in the high-frequency nasal cannula group, where the PF ratio was less than 200. So if there was a moderate degree of ARDS with a PF ratio of less than 200, then they observed low rate of intubation in that group of high-frequency nasal cannula group. So looking at some of the RCTs which used high-frequency nasal cannula in medical patients, there were a couple of them. The couple of them were Florally trial in 2015, and then Hernandez et al. In 2016. Those two groups compared high-frequency nasal cannula with NIV. What they observed, well, we saw the Florally trial results, that it is non-inferior to NIV. In Hernandez et al. In 2016, what they observed was similar rate of intubation rate. And then there was less respiratory failure overall in high-frequency group, and there were more adverse events with NIV. So that was observation by those two trials. Rest of them all had a comparison of high flow nasal cannula with conventional oxygen therapy. And what they observed was they reduced high frequency nasal cannula. It did reduce desaturation, reintubations, and mortality as well. So there is a clear-cut benefit when compared to conventional oxygen therapy. And majority of them agreed that it was not inferior to NIV. Looking at this meta-analysis, when it compared 3 trials with HFNC and NIV, there was not a superiority of high frequency nasal cannula over NIV, and it was definitely not inferior either in terms of intubations. If these patients were to be intubated later on, then there was no superiority of non-invasive nasal cannula over NIV. So that was the outcome of that meta-analysis, which was published in Intensive Care Medicine 2019. Again, the lower down forest plot says about conventional oxygen therapy, there is a clear-cut favoritism towards high-frequency nasal cannula in terms of mortality and progression of respiratory supports. So looking at high-frequency nasal cannula role in preventing reintubation. So within a group of cardiothoracic post-operative patients, high-frequency nasal cannula was not inferior to NIV in the BIPOP trial in 2015. The OPERA trial in 2016 for the group of patients who had subdiaphragmatic surgery, post-operatively, NIV was recommended in high-risk patients, and high-frequency nasal cannula was not better than conventional oxygen therapy. Whereas if you look at general critical care patients, if you have a high carbon dioxide levels, typically more than 45 mmHg, then probably you should be looking at NIV, preferring over high frequency nasal cannula. In case of high risk groups, high frequency nasal cannula was better tolerated. I repeat the word better tolerated than NIV. And for low risk groups, high frequency nasal cannula did have a more of a beneficial role. Well, looking at a preventive role of high frequency nasal cannula, there were RCTs which were looked at, and in group of thoracic surgery, high frequency nasal cannula did reduce length of hospital stay and reduced reintubations and episodes of hypoxemia. But if we were to look at abdominal surgery group, then there was no difference comparing conventional oxygen therapy and high frequency nasal cannula in reducing the reintubations or hospital mortality or hypoxemia. Let's look at the cardiac surgery group. There were 4 trials, RCTs, and if you were to look at high frequency nasal cannula comparing NIV, which was done by Stephen et al. In 2015, there was no difference in reintubation rate or ICU mortality. That was comparing high frequency nasal cannula and NIV. The rest of the RCTs compared high frequency nasal cannula and conventional oxygen therapy. There was no difference which was observed in the desaturations between those 2 groups. So that was observation in 3 of the RCTs in cardiac surgery group. But the NIV and high frequency nasal cannula difference was not observed in terms of reintubation rate and hypoxemia or mortality, according to Stephen et al. In 2015. Let's move on to the other group, which is obese critically ill group. High flows definitely theoretically tends to splint the collapsing upper airways. And there will be recruitment of alveoli, and there will be increase in functional residual capacity, and to a certain degree, PEEP effect will also be there. But what was observation by Corley in Intensive Care Medicine 2015, which was published, did say that prophylactic extubation onto high frequency nasal cannula in post-cardiac surgery patients with higher BMI did not lead to improvements in respiratory function. That was observation by them. Let's have a look at the other group, which is bronchoscopy. This is a commonly done intervention in ICU or outside ICU as well. And there were a couple of studies by Luke Angelo et al., who looked at the oxygen levels, the saturation, and PF ratio. They were all better with 60 liters of high flow when compared to 40 liters of high flow. So this was compared, these three things were compared: 60 liters of high flow, 40 liters of high flow, and the conventional oxygen therapy. So out of which, I think the 60 liters of high flow nasal cannula did better when compared to 40 liters of high flow and the high oxygen delivery normal devices. If you look at NIV probably achieves better oxygen saturation than high flow in hypoxemic respiratory failure patients. This was observation by Simon et al. There was probably a leaning towards NIV usage when compared to high frequency nasal cannula as per Simon et al. So routine use of high flow nasal cannula for patients undergoing bronchoscopy in critically ill patients is not very well supported as per the evidence. What if we were to pre-oxygenate critically ill patients with high flow nasal cannula? Well, there were few observations by Woruch et al., Jaber et al., and Simon et al. They did say respiratory failure patients pre-oxygenated with the initial work was by Woruch et al., comparing high frequency nasal cannula and non-rebreathing mask. Then Jaber et al. Observed respiratory failure patients being pre-oxygenated with high flow nasal cannula as against NIV and high flow nasal cannula. The other one did look at high flow nasal cannula versus bag valve mask ventilation, which was not statistically significant. So overall, looking at the evidence, probably high flow nasal cannula was not more effective in preventing desaturation episodes. So probably it hasn't got a good role. So what if high frequency nasal cannula, has it got a role in caring for COPD patients? Well, Lee et al. Did observe when compared between high flow nasal cannula and NIV, there was a similar carbon dioxide clearance at 6 hours and 24 hours. So also was the intubation rate and 30-day mortality. And their observation was HFNC was not inferior to NIV in post-extubation respiratory failure patients. So usually COPD patients have a failure rate post-extubation even with NIV. And their observation was HFNC was not inferior to NIV. Longini et al., what they observed was HFNC instead of conventional oxygen therapy could replace NIV weaning. So has it really got a role? Well, as observed, definitely there is a NIV failure in COPD exacerbations that we very well know and observe. And HFNC reduces the work of breathing, which is similar to NIV. So that has been observed. But CO2 reductions is not satisfactorily reduced. It does not necessarily happen. And then it can very well be used if there is a mild desaturation and if there is a mild reduction in respiratory acidosis. But what is the key message? So the real efficacy of high flow nasal cannula in COPD patients is not very well established. And then the target population amongst COPD exacerbations after extubation is not very well defined. So the role of HFNC in COPD exacerbation is not very well defined. Probably we should be looking at more evidences to come through. In palliative care, yes, there is a role, and dyspnea, which is a common symptom in terminally ill patients, is very well taken care of. Endotracheal intubation is something probably not appropriate in these group of patients, so it can very well be instituted. And we do know NIV impairs communication if it were to be continuously instituted. So, and then feeding comforts cannot be there as well. So probably there is a role. And Epstein et al. Did say that within the 183 patients observed that they observed, 41 of them did improve and 44% remained stable on high flow nasal cannula and 15% declined over time. And the mean time of high flow nasal cannula that they used was over 3 days. Peters et al. in respiratory care 2013, what they observed was saturations did improve and the breathing frequency was reduced with usage of high frequency nasal cannula. And 9 of the 50 patients did have escalation to NIV. And while 82% were being able to maintain on high frequency nasal cannula. And the mean duration that they observed with high flow nasal cannula in those group of patients was around 30 hours. So to close up that session, I think the high frequency nasal cannula, if it were to be used as a protocol in acute hypoxemic respiratory failure, this is one of the samples that I picked up and displayed here, that one has to be careful about initiation. After initiation, within 1 to 2 hours, you need to be monitoring the patient for presence or absence of prognostic factors. And if those prognostic factors were there, then probably you're not going to continue with high frequency nasal cannula and you would rather go for intubation and ventilation straight away. But if there are no prognostic markers, then you could pursue with NIV as a trial. And subsequently, if those prognostic markers were present with subsequent monitoring as well, then you would go on to intubate them if there is worsening. So HFNC has got a role within certain limits that the patient is improving and the patient is sustained without any further progression of the disease per se. So let us move on to the next session, that the role of high frequency nasal cannula in COVID-19 patients. So the next few slides would pan out in these way. What is the role of high frequency nasal cannula when compared with early intubation strategy? This is what there are some data that we have got on. And then the efficacy per se in COVID-19 patients, is there any evidence that we have got till now? And what are the evidences that we have got to date? And what are the recommendations from the major societies that we can take home? And what are the risks associated, which has been very well covered by Dr. Chandana in his talk on NIV as well. Does HFNC make a difference in COVID-19 respiratory failure? So this was a study coming from Spain, which was published in Critical Care 2021. And they looked at high flow nasal cannula in COVID-19 patients associated with acute respiratory failure. And what they compared was high frequency nasal cannula versus early intubation. So early intubation was one of the key strategies early on during the pandemic. And we very well know the work by Martini and Gattinoni, where they described these group of patients, COVID-19 patients, into 2 groups of low elastance and high elastance, and then the PCLI, which is basically the patient self-induced, self-inflicted lung injury, which is quite commonly described those days, and the importance of having high tidal volumes and the self-inflicted lung injury was highlighted by those initial papers. And there was a key emphasis that we should be moving towards early intubation. That was early on in the pandemic. So looking back at this paper, which compared high frequency nasal cannula and the early intubation strategy, they did have an inclusion criteria. Patient was RT-PCR positive. The patients were more than 18 years old, and the patients were included when they were admitted to ICU the very first day. The exclusion criteria, obviously, they were intubated earlier on, and the PaO2 FiO2 was more than 300, and the respiratory rate, if it was very high, more than 35, and if there was a reduction in GCS or if there was a respiratory acidosis, those patients were excluded. So what was their observation? With high frequency nasal cannula in this group of patients, there was a clear-cut ventilator-free days of up to 8 days by day 28. So how many days of ventilator-free days was there by the end of 28 days was up to 8 days with high frequency nasal cannula, which was much more higher than early intubation group. How many number of ICU days did it reduce? Nearly by up to 8.2 days. Was there any in-hospital mortality benefit? It wasn't the case with high-frequency nasal cannula, nor with early intubation strategy. So the early intubation was classified as the ones who got intubated on the very first day of ICU admission. So they did observe reduction in number of ventilator days and the number of ICU days. So should we be intubating COVID-19 hypoxemic patients early? Well, this was observation, and quite a few papers have come across later down the lane of this pandemic, which is ravaging the world. Tobin et al. Did highlight this caution about early intubation and mechanical ventilation in COVID-19 patients. The words were, even if high tidal volume and PCL play some role in the progression of respiratory failure in COVID-19 patients, for which there is no convincing evidence, this would not provide justification for liberal use of endotracheal intubation, for which there are decades of research documenting fatal complications. We very well know, we have been there, we very well know the complications of endotracheal intubation and ventilation. So there is a word of caution that needs to be exercised, that we don't intubate, ventilate straight away all patients who are hypoxemic. So have we got a greater role for high flow nasal cannula? Is it really a boon or is it a bane? Well, the paper by Abhishek Singh in critical care anesthesia in 2021 has an evidence base which has been reviewed very well. Let us look at what are the evidence bases that they have discussed. Looking back a step further, high frequency nasal cannula efficacy has been published quite some time in the early phases of the pandemic in 2020. And this is a summary of it, that most of the studies were from China, and Wang et al. In the initial phases with 17 patients, and they were all quite small number of patients to start with, and a couple of studies focusing on 100 odd patients. And their observation when compared to NIV in a couple of them and looking at the mortality was quite varied. So some of them observed that HFNC did play an extensive role, and they were successful in treating those patients, while some of them did not observe the similar success, and some of them did not have a great success either. So it was quite varied in the initial phases of the pandemic. And we very well know that during the pandemic, the treatment, what we tend to deliver to these patients have changed. For following the recovery trial, things have changed, and quite a few interventions we have learned through the pandemic has changed. So next few slides, we will whisk through looking at the forest plot, looking at certain parameters that the high flow nasal cannula, when compared to different other respiratory supports, how they have fared. So if you had to look at invasive ventilation, high frequency nasal cannula usage reduce the need for invasive ventilation when compared to conventional oxygen therapy. High frequency nasal cannula reduce the need for escalation of respiratory therapy when compared to conventional oxygen therapy. The forest plot favors towards the high flow nasal cannula towards the left. How about intubation rates? So here there was a comparison with conventional oxygen therapy. Intubation rates definitely was reduced when compared with the conventional oxygen therapy. But when it was compared with NIV, intubation rate was not inferior if we were to use a high flow nasal cannula. This comes from 3 of the studies. How about escalation of respiratory support and mortality when compared with NIV? So there was not inferior was the observation. So there was no benefit by using high flow nasal cannula when compared to NIV in terms of mortality or in terms of escalation of respiratory support. How about mortality benefit when compared to conventional oxygen therapy? Yes, there is clear-cut benefit in terms of using high-flow nasal cannula, albeit small. Length of stay in ICU, there was not much of a reduction. This was observation from 2 of the studies in the meta-analysis. How about hospital length of stay? Yes, there was a favorism towards high-frequency nasal cannula usage in reducing the hospital length of stay when compared to conventional oxygen therapy. How about patient dyspnea? Patient dyspnea definitely was reduced by use of high-frequency nasal cannula, and so was the patient comfort level. There was a clear-cut demarcation towards HFNC. I wanted to highlight this study, which was done from South Africa by Caligro et al. This was published in 2020, and what they looked at was the utility of high-frequency nasal cannula in severe COVID pneumonia patients. And within a resource-constraining setting, what was their observation as a multi-center prospective observational study? Well, every patient that was included was on a reservoir face mask up to 15 liters per minute prior to initiation of high-frequency nasal cannula. And I want to emphasize that these patients were very sick. PaO to FiO2 ratio was quite low. It was less than 100. And the duration of symptoms prior to treatment with high-frequency nasal cannula on an average was up to 7 days. And the comorbidities were observed to be diabetes, hypertension, obesity, and HIV positivity. Quite significant comorbidities were observed. And the treatment that they received was universally anticoagulated, up to 96% of them, and nearly 76% of them received steroids. This was the time when recovery trial was released, and the results following which they were using the steroids, but even prior to the trial, they were using steroids. So nearly 3/4 of them did receive steroids. And most of the patients were treated with high-frequency nasal cannula outside ICU. That was their group. If you look at those numbers, nearly 300 of them, and nearly 47% of the patients treated with high-frequency nasal cannula were successful. And the failed patients, nearly 53% of them, of which 70% got intubated. And nearly 1/3 of that failed patients went on to die. And if you had to look at this plot where the failure rate was ascertained to the ROX score, which we will deal with in the next section, the respiratory rate oxygenation index, the formula will be displayed in the subsequent slides. The demarcating cutoff value was 2.8 at 2 hours, 3.4 at 6 hours, and less than 3.8 at 12 hours. If this parameter were to be observed, which they did in their study, they were very good predictors of treatment failure. So this is something to take from this study, and subsequent slides we will emphasize upon. Having instituted high-flow nasal cannula, when should we know to escalate therapy? When should we know that it is failing? So that is a key aspect to the treatment of patients in COVID-19 hypoxic respiratory failure. So they found amongst the components of this ROX score, the pulse oximetry saturation reading and the FiO2 that they were on had a greater weight when compared to respiratory rate. If you look at this validity of the ROX scale, yes, it has been very well validated with a good sensitivity and specificity as depicted in the chart on the left. So there was a successful treatment with high-frequency nasal cannula nearly in 47% of the patients, and the mean duration of high-frequency nasal cannula usage was 6 days. And if there was a failure, then they went on to get intubated within 2 days. So this was observation from that group. Well, moving on to the recommendations by the international societies, apologies for the poor display of the slides. The Argentinian, Australian and New Zealand, and from China, European Society, Irish Society, the Spanish, Portuguese Society, and the American societies, including WHO, did have a say that high frequency has got a role in the management of patients. So they were suggesting the role of high frequency nasal cannula. Who did not approve of it? Probably Germany did approve of helmet NIV usage and restricting the use of high frequency nasal cannula. And NHS UK was preferring CPAP over HFNC. And there was also a suggestion from WHO that high frequency nasal cannula may not be a choice for COPD patients and those patients with hemodynamic instability. But with certain caveats that has been expressed, majority of the societies did go for suggesting high frequency nasal cannula as an armamentarium in the management of patients with hypoxic respiratory failure. So here is the summary of recommendation by the American Society of Critical Care Medicine and the Surviving Sepsis Campaign, having said that the high frequency nasal cannula can be considered in the suitable patients. So that was the recommendation by them. Looking at the safety aspect, well, with NIV as well, with NIV as well, we did have that. Just excuse me for a minute. That high frequency, the safety aspect element of it, which has been very well described in the previous talk by Dr. Chandana, that what about aerosolization of the COVID patients undergoing HFNC? Well, Agarwal et al. Did have a look at it. The Hfno nasal cannula for hypoxemic respiratory failure patients, they did have a systematic review of its effectiveness. That was review number 1. And review number 2, what is the risk associated with it? So this was published in Canadian Journal in 2020, and this was WHO initiated review by a group of panelists. So what did they observe? Review 1, they did compare a high frequency nasal cannula with conventional oxygen therapy, and they observed that you have got a role in reducing the intubation rate and also reducing the escalation of care from respiratory support perspective. And the review 2, they did evaluate the droplet dispersion, aerosol generation, and the infection risk, infection transmission associated with high flow nasal cannula. The efficacy and safety and dispersion during the high frequency nasal cannula usage, there were quite a few studies in terms of 12 RCTs. There were 4 studies looking at droplet dispersion, and 3 did look at the aerosol generation and dispersion, and 2 simulation studies, and the crossover study, which also looked at it. And the general observation was these 2 directly done studies using high frequency nasal cannula, Guy et al. In 2020, which was published in Respiratory Journal, did observe after 30 days of follow-up, only 1 of the nurses who took care of patients within their unit developed positivity. And again, Abin et al. In 2020, which was also published, comparing high frequency nasal cannula and NIV, looking at the samples observed from the patient surrounding, nearly 13 out of 28 environmental samples did test positive for a viable virus, but the air samples were negative. So these are the directly done studies on group of patients in the current climate of clinical settings. If we were to take it from them, rest of them were simulation studies And if we take anything from these two studies, the risk of transmission remains extremely low. So going on to the next session in terms of high frequency failure per se, which is the most important aspect I wanted to highlight, we need to be looking at the use of respiratory rate oxygenation index as a follow through. Have we got a protocol to follow using these numbers? Yes, probably we'll look at it as well. And there are certain factors which we need to consider prior to initiation of high frequency nasal cannula and after initiation of high frequency nasal cannula. And is there any way of having scoring systems which can predict? Yes. And some of the indications related to predictive parameters later on while on high frequency nasal cannula. Looking at the ROX index, it has three parameters to it. One is the saturation. What amount of oxygen are we dialing in? The FaO2. So saturation divided by FaO2. The whole ratio divided by respiratory rate will give you the ROX index. And for example, this quantifies the number, a saturation of 88% on FaO2 of 0.7 with a respiratory rate of 28 will give you a score of 4.4. If it were to be observed at 6 hours, probably you would continue with high frequency nasal cannula. So what do these numbers translate in terms of clinical practice? So I would like to quote this paper, Ricard et al., published in Intensive Care Medicine, looking at these ROX numbers. They qualify at 2 hours, 6 hours, and 12 hours. And at 2 hours, if it is less than 2.8, well, probably you should be looking at intubating these patients. What if it is in a range? Then you need to monitor them and observe the change. So the delta ROX score, does it change at all? If the delta changes by more than 0.5%, we are reasonably okay to continue monitoring. And then at 6 hours again, the value is, the cutoff value is less than 3.4, where you're looking at intubating the patients. And if you're in the yellow zone of a reasonable number, then you would go on to monitor them, look for the delta change. If it is more than 0.5, then we are okay to continue. And look at the ROX score at 12 hours. If it is less than 3.8, we can consider intubating those patients. There is a failure. But if the score is more than 3.85, you could further monitor, look for the change in the ROX score, and continue monitoring. So this is an algorithm by Ricard et al., which they have come up with in their study. So what are the pre-high frequency nasal cannula parameters that can predict failure? If you've got a high SOFA score, high SAP score, then they are likely to fail. If there is a hemodynamic instability as recommended by WHO, then probably you've got a failure with high frequency nasal cannula. If there is a severe ARDS, PF ratio less than 100, then the chances of failure is high. And a respiratory acidosis, if it is less than pH of 7.35, again, failure rate is high. And if the GCS is low, probably we would not even be considering high frequency nasal cannula. What about post high frequency nasal cannula usage? Well, we have seen the ROX index. And if there is a failure to show rise in PF ratio after 12 hours, again, you need to be rethinking whether high frequency nasal cannula is helping them. And as early as 2 hours, if there is a persisting dyspnea, respiratory rate is not controlled even by increasing the flow and the saturation maintained less than 88%, probably there is a failure that's ensuing. What are the predictive scoring systems? Well, Messica et al. Did observe SAPS2 score. If it is high, it is an independent risk factor. Again, Koga et al. Again similarly observed the same. And also wanted to touch upon the indications. So per se, if you're going to use high frequency nasal cannula for a patient with PF ratio less than 100, then the failure rate is high. This was depicted in the Florelli trial. What about a patient with PCP pneumonia? Probably if they have got a higher SOFA score, And if there is non-improvement of PF ratio at 6 hours, then they are likely to fail. And what about HFNC as an indication for post-op patients? So post-op patients, post-operative patients, you're weaning off invasive ventilation. In those group of patients, if you've got a higher SOFA score, or if the BNP levels are high, and if there is a tachycardia, then the likelihood of high frequency cannula failing in them is also high. The next session, probably next few slides, I'll touch upon quickly the experiences at our hospital. COVID-19 patients, ever since May last year, we have been admitting patients, and nearly 90 odd patients had episodes of high frequency nasal cannula instituted in them in ICU alone. And apart from ICU, in HTU, high frequency is being delivered. And in non-COVID patients, in the main ICU, we have been using them as well. Out of the 129 patients admitted until a couple of months ago, 90 patients had episodes of high frequency nasal care, and on an average, they had spent 4.5 days during their care. And from our experience, what we can say is initiation of high frequency nasal cannula has to come from the physician with the respiratory therapist who are taking care of these patients on a regular basis 24/7 in our ICU. They've got a stronger role in terms of monitoring, and the nurses do have a role in monitoring the patients and then reassessing the patients apart from the physicians in initiating it. And in terms of monitoring patients, which is very vital, the bedside clinical signs, we do have a monitor, and apart from the clinical sign vital monitoring systems, we do have camera monitoring systems as well for continuous monitoring purposes, that you can take the cue from terms of respiratory discomfort, whether there is any excursions, and all the other clinical bedside signs apart from the bedside observations. You could continue to monitor them, and the numbers from ABG and the bedside vital monitors can clearly tell you whether there is a failure in terms of high frequency nasal cannula that's being deployed for these patients, or can we continue to monitor these patients. So monitoring is very vital for these patients, and an appropriate escalation of care, if things were to deteriorate, has to be done at the appropriate time. So I cannot emphasize anymore in that perspective. So nearly 23 out of 90 patients within our observation went on to require invasive ventilation. So 25% of those patients who had HFNC went on to have invasive ventilation, and the mortality was nearly 8.8%, and 4 of them got discharged against medical advice. And another key emphasis I wanted to make, again, like NIV, we need to be thinking about prone positioning, and with a prone position and high frequency nasal cannula makes a drastic difference. If prone position is not possible, think about semi-prone position, lateral position as an alternative. And the more number of hours they spend in these positions, it does help. And especially somebody who is on a high NIV, high frequency has got a role bridging them when they are off NIV while taking food. So we do that regularly as well. NIV patients on NIV having food break, or any other kind of break for communicating with the family, they do go on high frequency nasal cannula. So you could see those 2 patients, one of them after a prone position, the other one spending the time on a semi-lateral position, semi-prone position. So this is one of the clippings. Does high frequency nasal cannula need high oxygen? Yes, at a very high dialed FaO2 levels, it does require quite a high levels of oxygen, but it not necessarily be taken as out of the armamentarium. High frequency nasal cannula, a big no-no in the light of low oxygen availability. Well, probably that is not true. It could probably be a myth in the overall management of the patients, where you can resort to having an appropriate target for the patient, which could very well be a saturation of 92%, and then quickly reducing the amount of FiO2 needed for that particular patient by a close monitoring of the vitals and taking appropriate monitoring in terms of respiratory rate and saturations, looking at the ROC score and reducing the amount of FiO2 that they need. So with that, I think probably we'll summarize. HFNC success has to be considered in these associations. How many hours of HFNC per day can we deliver? Which is the right amount of duration that they spend on high frequency nasal cannula for them to be successful? What are the other associations like prone ventilation or lateral ventilation to be instituted in them? And then, is there a right protocol for initiating it? Do we adhere to it? Is there a good monitoring technique that we follow, and an appropriate regular assessment of those patients to escalate care or to continue high frequency nasal cannula? These things should be thought about. And then definitely one has to be cognizant of the fact that there could be a failure in terms of high frequency nasal cannula. Early recognition clinically and supporting with escalation of care should be instituted at the right time so that we rescue more patients. So to summarize, high frequency nasal cannula has got a potential beneficial role in multitude of clinical conditions, which we saw in the initial few slides. And it is an effective tool in the early, mild, and moderate type 1 respiratory failure amongst the COVID-19 hypoxic respiratory failure patients. And high frequency nasal cannula could reduce intubation rate in these group of patients, and also could potentially reduce reintubation rate in post-operative group of patients, differently another set of patient group, and cannot emphasize that needs a close monitoring to identify failure and institute appropriate escalation of care, be it intubation at the earliest opportunity. And if we choose the right patients, the outcome can be better with high frequency nasal cannula. And I take this opportunity to thank the organizers for the opportunity, and my team who have been through and through during the pandemic, helping each other, and Dr. Eman Shivkumar for heading the department all the way through this pandemic. Thank you.
Thank you very much, Dr. Vivekanathan, for updating us on how to use and what is the evidence available at the present moment in use of high frequency, high flow nasal cannula. And I think we have come to the end of the session. Although we are like, it's 7 o'clock, I am sure that people will remain, because it's the most interesting part next to answer some questions. There are quite a lot of questions. I have sort of selected some which might be more relevant to the participants. I think the panel can select what is relevant. This is, I think, more Chandana's talk. CPAP and pressure support, CPAP with pressure support and BiPAP. Is it same or two different things?
That's a good question. So the question is CPAP and pressure support and BiPAP, two different. So basically, the effect is the same, but the devices, the dedicated devices for BiPAP, they use different methodology to sense the patient's effort. For example, the dedicated BiPAP devices, they sense the patient's breathing effort at the patient and closer to the face mask. You get a certain tubing, pressure sensing tubing, so that you can quickly sense the breath, so the patient feels it's more responsive with dedicated BiPAP machine. But otherwise, if you look at the pressure swings, like it's the same thing. Like when the patient triggers the ventilator, so they get the same kind of pressure effect. But how the patient feels, the response, the quickness of the response is different. Otherwise, the physiological effects are the same. CPAP with pressure support and BiPAP, they have the same effect. The only difference is depending on the device, the cost of the device and the type of how the ventilator interacts with how rapid the patient ventilator interacts with the patient is different. Otherwise, the effects are, you basically have the same effect, and we can basically call CPAP and pressure support is equivalent to BiPAP.
Thank you. Right. Somebody is asking, is the tidal volume the only important thing in non-invasive ventilation? What about the respiratory rate?
Yeah, so respiratory rate is also an important parameter, but if you have, especially if you have a lower kind of PEEP where you have more ROCA or the more atelectroma happening during the breathing, the respiratory rate can actually produce a lot of mediators. But generally speaking, rate alone is not the primary thing. I mean, you can withstand certain degree of because every time the valvuli just open and close from the moment you are born until the day you die, so that is designed to collapse and open but not completely collapse. So if you have a reasonable PEEP, the respiratory rate has got a very little effect, I mean practically, but tidal volume has got a very large effect, especially when you have what we call babula, when you have fluid filled alveoli in the lung and when you have a functionally low lung volume. That is the important thing. I mean, there are methods of finding out what is the functional lung volume in a ventilated patient, but it's difficult in a NIV patient. So it's important not only to ventilate that part of the lung. So your tidal volume should accommodate only ventilatable part. I mean, if you try to give a larger tidal volume, then it's going to cause a lot of volume trauma, and you go along that death pathway with multi-organ failure and death. So it's extremely important, but it's in IV it's difficult to figure out what is the functional lung volume, but in ventilated patient it's quite easy. So if you paralyze the patient, and when you paralyze the patient, the transpulmonary pressure difference becomes plateau minus PEEP. But if you don't paralyze, then you can't get the plasma pressure difference. So that is your driving pressure. And if you keep the driving pressure less than 15, so what you do is you multiply your compliance with the driving pressure. So if you have say compliance of 20 and your driving pressure you multiply by 15. So compliance multiplied by 15, that is your functional lung volume. So 15 into 20, some 300 ml tidal volume. So that is the tidal volume which can accommodate the lung. And if you give more than that, sometimes you'll have to give slightly larger, like 350, something like that. You can't control exactly in a patient. But if you give larger tidal volume, then you know that you are causing a lot of mediated release, and the patient will gradually deteriorate within a few days. But it's not apparent. But the bad thing about this NIV and invasive ventilation, a lot of people think when you give large tidal volume, you quickly see an improvement of saturation and blood gas value, even the X-rays. So there are certain people, probably sometimes because they are used to the high tidal volumes, and even when I started, I remember the ICU I used to work with had a 15 ml per kg tidal volume. I mean, some 800, 900, which I'm very old, if you can guess my age that way. So anyway, so if you give large tidal volumes, then it causes a lot of damage. So it's important to limit the tidal volume. So one way of limiting tidal volume is to guess the functional lung volume by multiplying your static compliance by 15. That is the probable lung volume the lung can accommodate, and anything more than that can damage the alveoli. But sometimes you'll have to do it, but you have to limit the amount of volume, added volume, more than your functional lung volume. So tidal volume is the crucial thing. Respiratory rate is important, especially if your PEEP is low enough, so that you get, we don't know. I mean, if you get, so you can see the recruitability by various means, especially with the invasive ventilation, but non-invasive difficult. Invasive ventilation, you can do what we call low flow pressure volume loop, and you see a hysteresis, big gap. That means a recruitable lung, and there are other methods also. NIV is difficult. NIV, so you have to rely on the tidal volume and guess the transpulmonary pressure, or you have to use the esophageal pressure and look at the swings to get the transpulmonary pressures. Rate is important, but tidal volume is much more important than the rate.
Question is, yeah, you want to say something?
Madam, I think if I could add to Dr. Chandana,
yeah,
this question was regard to non-invasive ventilation and whether the tidal volume and respirator are important. So both are equally important. What I would add on, I think tidal volume, I'm sure we are all agreeing to a low tidal volume ventilation when it comes to ARDS, or even in anesthesia patients. I think it is proven beyond doubt that now we have to use a low tidal volume ventilation. I think we are all confining to it. Sometimes on a NIV, patient try to generate a larger tidal volume. I think it becomes, though you try to come down on your pressure support, they try to generate a larger tidal volume. That will be a concern in these kind of patients who are subjected to further lung injury. As far as the respiratory rate is concerned, what I would like to add on is, so this is an important parameter which you would like to monitor during an NIV trial. So whenever you initiate a non-invasive trial, I think most important is the monitoring, and you decide on early switch over to invasive ventilation. So if you don't switch over to an invasive ventilation at an appropriate time, probably you will end up with some kind of cardiac arrest or a catastrophe. So as far as this is concerned, I think the respiratory rate is an important parameter. So if you see the patient rate not coming down, the distress not coming down, they are fatiguing, your blood gas, you don't see a favorable change in pH and PCO2. I think these are indicators which will indicate to switch over to an invasive ventilation at an earlier stage. So respiratory rate is an important parameter. You need to watch it closely. So if it is on the higher side, probably it indicates an early failure of non-invasive ventilation, and you need to switch over to an invasive ventilation. I think so. This is a message I would like to convey.
I fully agree with you. I was just mentioning about the lung injury, like immediately release, but as you, I'm 100% agree with you. That is an important parameter, and that is, I agree with you. We have to change over something. But I was just concerning about the importance of the immediate or release. Otherwise, it's a very important parameter. I fully agree with you.
I think that gives the answer to the do you recommend NIV in severely tachypneic patient with large tidal volume? I think the answer is there. Another question is, I think, addressed to all of you. How far is it cost effective to use NIV in oxygen shortage, and how can you weigh the advantages and disadvantages when you compare the amount of oxygen consumed between high flow nasal cannula versus NIV?
So, do you want me to answer that one?
No, anybody. I mean, it concerns both sides.
Okay, so I'll talk about NIV. So NIV, if you have a lot of leaks, of course you can lose a lot of oxygen, and so you may not be able to compare Hfno and NIV, especially if you have a lot of leaks. But with a person who can who concentrate on the proper mask seal. So if you have minimal leak, probably so you only get a higher kind of flow during the inspiration, and the patient is not generating larger tidal volumes, high flows, and you are not using very high pressure support. So NIV can potentially save some oxygen, but as he said, the high flow also, I mean, if it is working and you gradually come down, so high flow may sometimes you can actually save oxygen, but it depends on, but it, as a technique, I mean, as an entity, NIV and high flow, to get the same kind of oxygen level, FiO2, so you can actually use less oxygen in NIV theoretically. But whatever actually happens will depend on the patient's kind of response to the NIV and high flow. So it's a kind of multifactorial thing. But as the technique itself, NIV can save some oxygen compared to high flow, especially if you need to use 100% oxygen with a higher um, um, higher drive, respiratory drive with high flow nasal cannula, you need to apply 60 liters, probably sub 60 liters continuously. You can imagine how much oxygen we are losing. But at the same time, if the patient is improving, and if the HN high flow nasal cannula is working on the patient and improving, probably you will serve more oxygen, because we might keep the patient on NIV for a longer duration. So it depends on, it's multifactorial. But as a technical point of view, high flow nasal cannula with high oxygen concentration, high flows, will waste a lot of oxygen, but it doesn't necessarily mean you are wasting. But technically that is the thing. So high flow nasal cannula, you use less oxygen compared to, sorry, NIV you use less oxygen compared to high flow, as a technical theoretical.
If I may have to add on to that, thank you, Dr. Chandana. Per se, high flow nasal cannula doesn't have to use very high oxygen flow. For instance, if you were to dial initially 60% FiO2, 60 liters of flow, then it is not 60 liters of oxygen. So it is only 60% of the 60 liter, so which will roughly come up to 30-35 liters of oxygen. Well, it is high when compared to NIV, agreed. But having said that, how far does that patient need the same level of support, 60% oxygen and 60 liters of flow? So this is something that we need to follow through and then see if the patient can come down on that particular support. Usually the support will be reviewed within 1 hour or 2 hours of time. And if it makes a difference and the saturation which is being targeted, if it can be individualized for that particular patient, even to a level of around 92%, which we tend to do, that can dramatically reduce the amount of need of such a high FaO2 that is being dialed. So if it can be reduced to 40% oxygen at a 60 liters of flow, then you're coming down on the amount of oxygen that is being used straight away. So I agree in principle, high flow oxygen therapy will need higher oxygen if it is dialed at a higher percentage of FaO2. And if the liters of flow, which is basically a blend of oxygen and air, then you're using higher oxygen levels initially. But if it can be brought down quick enough, and if the targets are kept at a reasonable level, say to 92% or so, in most of the patients, then you're probably coming down on the usage quite quickly. So that is the only point I were to make, if I were to make. And if we are having a scarcity to a greater level, then probably you're looking at moving towards NIV. If that is what we have, probably the usage will be slightly lower. Whereas at the same time, I have to highlight, if you're going to use 15 liters of oxygen per minute through a non-rebreathing oxygen mask, and there is quite a bit of leakage, and the leakage is unaccounted for, then probably you are better off in that particular scenario where there is a leakage of oxygen as well. 15 liters are going away anyway with a conventional oxygen mask, then probably you'll be better off with the invasive technique, be it high frequency nasal cannula or NIV in that particular condition. So that is something you need to consider as well.
Yeah, somebody has asked your experience, how many high flow machines can be used roughly at the same time with a conventional VIE oxygen supply with 4-bar oxygen supply? Have you done any calculation into that matter? Because everybody is concerned about high usage of oxygen during this COVID times.
We do have a liquid oxygen supply. I think Dr. Shivkumar will be able to add on to this. And the number of machines is reasonable enough in a 12-bedded unit. So we have never gone short of high frequency machine as such for carrying these 12-bedded unit patients. And most of the time, it isn't a problem with the liquid oxygen supply till date. I think with regard to numbers, I think Dr. Shivkumar can fudge in.
Madam, with your permission, I think I looked at a few questions which you asked about the oxygen crisis and usage of high flow nasal oxygen, and some of them comparing between the both and using NIV in place of Hfno failure. I think I would like to answer all it together. So I think a week or 10 days before, I think even most of the places in our state had a crisis. At that point of time, I think we have advised all our colleagues to come down on the usage of high flow nasal cannula and try to use NIV as much as possible. But as the oxygen supply got better off, now I think we are trying to use Hfno wherever needed. So when we had a constraint, I think we have moved totally from the high flow nasal oxygen to a NIV because the consumption is quite high. But now we are back on it. So what we do is, I think most of our HD or ICU patients, we do give a trial with high flow nasal cannula. And a lot of them, I think in the first wave, they did very well with high flow nasal cannula. But in this wave, some of them are not tolerating high flow nasal cannula. Some of their workup breathing is quite high. Some of them we have to switch over to NIV. That is an observation. So unlike the first wave, where most of them did well on high flow nasal cannula, and we have to use very little of NIV. This wave, I think a lot of them were started on high flow nasal cannulas. At least majority of them, I think we need to use a bit of NIV as well. Sometimes we try to use a few hours of high flow nasal cannula and then bridge it with NIV. And how our nurses use is somebody who is very hypoxic, who are on NIV during the time of food intake, they try to put a high-flow nasal cannula, and other times I think they try to use NIV. So they try to combine and use both NIV and high-flow nasal cannula as well. And if you look at the literature which compares head-to-head high-flow nasal cannula versus NIV, I think Vivek will agree with me. There is no superiority of one over the other in terms of the ventilator-free days or respiratory failure. So these are the few things we need to take into consideration. So when you have constraints, the constraints is very severe, probably you should look at using more of NIV rather than high-flow nasal cannula. If you don't have an oxygen constraint, I think you can use it based on the patient need. So in all our patients, we had given a trial of high-flow nasal cannula, but in this way, some of them didn't do well with high-flow nasal cannula. The workup breathing is very high. So we did switch over to NIV. And always our protocol is in some patients who fail high-flow nasal cannula, before we switch on to invasive ventilation, we give a trial with NIV. So we don't straight away go for an invasive ventilation once who fails high-flow nasal cannula. Some of them you can tide over with the non-invasive ventilation. But as far as the literature is concerned, there is no, as I know, there is no trial which claims superiority of one over the other.
Okay, thank you. And in this question to Chandana, what is the acceptable leak percentage and how much of leak is compensated by a single limb unit, non-vented mask with leak ports and filters? And how much of percentage of leak is acceptable in NIV? Those are the two questions.
Yeah, so I can't actually give you a
I don't
exact
think
value offhand, but generally I usually uh, any tool I use, I look at the patient and what happens to patient. So if you use say single limb circuit and you use certain amount of say oxygen and the pressures, and if the patient is getting certain the required effort, so I look at the patient. So in single limb circuit, it's difficult to measure the leak because the flow sensor, you have only one flow sensor. So inspired volume, we don't know how much patient actually exhale unless you measure it using some other method. The ventilator itself cannot deliver the exhale tidal volume, so you don't know what actually leaked through the ports. And single limbs are usually designed to generate a lot of flows because there's inherently there are a lot of leaks in the single limb circuit because patient is exhaling from the patient end. And so exact value I can't say, but I mean, if you leak say 30%, 40%, I think it's a big value. I think it should be less than that one. I can't give you an exact value. I don't know exactly how to answer the exact value. But generally, what you should concentrate basically on the proper mask fit, and then what happens to patient, whether the ventilation has improved, whether the values have improved. That should be the I usually go by the patient's effort. Even the method say if I want to get oxygen, whether to use high flow or NIV. If I need oxygen, then I would use some kind of method, a comfortable method. For example, as he said, the 60%. So if you're going to get 60% oxygen, so if you need 30 liters in high flow, and if you need 10 liters is enough for a Hudson mask, and if you need 15 liters for a non-breathing mask. So I would use whatever the measure available, comfortable for the patient, and see whether the patient's oxygenation has improved. Likewise, whether you use whatever the method, you have to focus on what is your requirement for the patient, and then try to see whether you achieve that target. So basically, I don't know exactly what value of figure the leakage percentage, but it's not very high. Like it's not 30% or more. It should be less than that one. But in single limb, it's extremely difficult to measure because you have only one flow sensor in the patient end, and you only measure the inspiratory one. Exhalation goes from outside. Dual limb, of course, you know what the leakage is. But still, so you have to have, I mean, I don't know exactly, but probably 15%, I would say. It's not very high value. You should minimize the leakage by having a significant homogeneous seal around the face. I'm sorry, I don't know the exact value of anyone. If they know, they can answer that question. I don't know exact values.
I agree with you. I think the leakage has to be something like, if you were to put a number to it, I think anything less than 15%, 10% will be ideal. But typically all these patients tend to have a NG tube, and then the interface is something that you could focus upon. And then if you could improve the leak percentage, reduce the leak percentage, then it will be of greater help. But yes, it can very well be tolerated to a certain extent, up to 10% maybe.
I think the most important thing is to monitor the patient and see the how he does. So close monitoring is very important, whatever method you use, isn't it? Yeah. Okay. The other thing is any chances. How is the chance of aspiration when you feed when the patient is on an IV?
That of course, if the patient, if the patient is having a good conscious level, it should not be a big problem unless you feed a lot of feeds to the patient. I don't think patient will need a lot of feeding. They won't, in a critical ill patient, I don't think they are that hungry to have a very big meal. But if the patient is conscious enough, they should have protected airway. There should not be a problem for simple meals. I don't think it's a big problem. But if the patient is conscious level deteriorating and you don't have any other option, you have to be careful. And especially when you give NG feeds, you have to be careful because the liquid material and sometimes if you give especially sedatives to calm down the patient, then there is a risk of so there are certain parameters, certain factors affecting for more aspiration. But if a conscious patient having a good mentation with a GCS of 15 with not on any sedatives, I don't think it's a big concern about aspiration. But if the patient is on sedatives and you give a large volume NG feeds, of course, they are at a higher risk of aspiration.
Particularly,
Thank
this
you.
happens with the tube feed, and particularly with the nasogastric tube in place, the lower esophageal sphincter may not be closed, and these patients swallow a lot of air. And with aerophagia, there could be a possibility of regurgitation. Even then, if patient, as Dr. Chandana mentioned, if he is very awake and alert, I think he's not going to aspirate. So this happens with people with low GCS when they're on tube feed, when your lower esophageal sphincter is slack. So when they swallow a lot of air, there could be a possibility of regurgitation and aspiration.
Do you have any experience with using CPAP mask on pediatric patients? I think it may be difficult for them to keep CPAP for a long time. In pediatric patients,
We don't have much experience on handling pediatric patients. Dr. Chandana?
No, I don't also use I have managed patients 10 years, 12 years, but I don't have experience in managing very low pediatric. I managed the patient for more than 1 month because that patient was a syndromic child. The mother didn't want to intubate the patient. So I had to manage that patient. We don't usually manage, but I had 2 patients who one was an adult patient and this child was, I think, more than 1 month. I had to ventilate that patient on this thing. But they did well. But only thing we find it difficult to get a proper mask because they come in different sizes. But the pediatric mask size, it's not available in our interest. So I had to find a mask, and that was my biggest difficulty. So I don't have a lot of experience in managing children with NIVs.
Another question is for maybe Dr. Vivekanathan. In case of failing high flow or NIV, what are the recovery rates at your centers for invasive ventilated severe COVID pneumonia patients? Maybe rough amounts that after failing the non-invasive techniques.
Well, I think if they fail high flow nasal cannula, they tend to have a trial of NIV. I think this was touched upon by Dr. Shivakumar as well. So after NIV trial, and if even that is not proving to be helpful, then they go on for invasive ventilation, and subsequently invasive ventilation has helped quite a large chunk of patients. But depending on how severe the disease is, there's a multitude of factors that is going to be involved later on, and how severe the disease is, what are the comorbidities that they've got, and then the secondary infections that tends to ensue later on. I think all these factors comes into play. But overall, I think it has been a fruitful exercise that not necessarily all patients who get intubated ventilated have a poor outcome. No.
Do you have any rough numbers, rate that you can give for the patients so far you have intubated and ventilated?
Not
yet.
Not
right?
out of the blue. No.
Okay.
Dr. Shivakumar would like to
If
add
I have to share the experience, our center experience, comparing our first wave and the second wave. The first wave, I think the people who needed invasive ventilation were not that high. Even the people who needed invasive ventilation, I think over a period of time, I think 10 days or 2 weeks time, we were able to wean them, and some of them needed tracheostomy, and probably we could get them off ventilator. But in this second wave, particularly patients who get ventilated, I think they take a long time to turn around. I think they need a prone, most of them need a prone ventilation. And even in prone ventilation, I think they take at least 10 days, 2 weeks to turn around. And then I think the results are not as encouraging as compared to the earlier wave, particularly in patients where you ventilate in the third week. Suppose you have a patient who come in the first week, they deteriorate by the end of 8th day, 9th day, you tend to ventilate them. I think they turn around quite faster compared to somebody who's coming in the end of second week or early third week, and these patients in turn get ventilated. I think they do spend a lot of time in ventilator and the outcomes are not very bad. So what I mean to say is, these wave compared to earlier wave, the patients who get ventilated take longer time to turn around, and particularly patients who get ventilated in the end of second week or in the middle of third week, they don't do that well compared to someone who gets ventilated earlier.
Thank you. Is there a place for high flow nasal cannula in asthma?
And I think probably it doesn't. There are not much of papers highlighting the use of high frequency nasal cannula in asthma. I think that was a reason it did not figure in my talk either. But it has been tried. It has been tried primarily coming from high frequency nasal cannula, higher usage in the early days prior to a decade or so in the pediatric group. I think that is where it has been used most. But per se, in adult population, high frequency nasal cannula usage in asthmatic patients is dismal. It hasn't been very well validated, and probably I may not be using it either.
Okay, I think thank you very much. I think we are coming to the end of this very interesting webinar on updating the participants on how to manage oxygen therapy in COVID patients using non-invasive techniques. So I would like to thank all the speakers, Dr. Chandana Karunaratne, Dr. Sivakumar, and Dr. Vivekanathan for that excellent discussion also. Dr. Bimal Kudavidanage, who is the head of our critical care faculty, for organizing this with Niroshan from Fisher and Paykel Company, India, to enlighten us on the methods of using oxygen on COVID patients. Thank you very much, and stay safe. Good night.
Thank you. Thank you, Doctor.
Thank you.